Hello everyone. So this case is a good one. It's very important and high yield. Okay, so you see 63-year-old woman. She's poorly responsive. So not responsive in her apartment. And then she became lethargic, complains of poor hearing, okay? And there is warm extremities, and then you do labs, right? You do labs, you check the anion gap. The anion gap is high, right? It's like almost 30. Anion gap 30, it's very high. So the normal is 12. You check liver enzymes, LFTs, high LFTs, high liver function test, and alkaline phosphatase. And what does that tell you? So when you check the ABG pH 7.49, PCO2 was 20. So there is only one condition that causes that. What is that? Causes hyperventilation, metabolic acidosis, and respiratory alkalosis. This is caused by salicylate toxicity. That's a diagnosis. If they ask you about diagnosis, okay, and they tell you what's the best next step, or which one is most beneficial in helping this patient. It's called forced alkaline diuresis for salicylate toxicity, okay. And usually that's how it usually present, like tinnitus, fever, vertigo, nausea in mild cases, and diarrhea. And in severe cases you can have hyperthermia, non-cardiogenic pulmonary edema, and altered metastasis. This is a severe case. Acid-base disturbance, you will see respiratory alkalosis with or without increased anion gap metabolic acidosis, okay. And the labs, you can have elevated prothrombin level, low serum uric acid level, and mildly elevated liver function test, okay. So the way you treat that, you add bicarb drip, intravenous bicarb, to promote renal excretion of the salicylate intoxication, okay. Salicylate toxicity, you want to give them bicarb drip, okay. All right. Right now, this is another high yield case. You see 37-year-old woman comes in with confusion and headache, fever, jerking, myoclonic jerking. So you do the PCR, okay? You do lumbar puncture. PCR is positive for HSV, right? So what do you start? You need IV acyclovir. It's important to treat this possible HSV meningitis. So what would you do best next step? You want to give normal saline 125 cc an hour with acyclovir. Why? To maintain urine output of 75 cc an hour. So you need to maintain good urine output, okay, for these patients. Now you have another patient. It's also another interesting case. You see 71-year-old came in with anorexia, nausea, and diarrhea. So you do labs. So after anorexia, nausea, diarrhea, you do just regular labs, just like for everybody you do. What do you find? So this is what you find. You find the serum, the BMP. So you find there's no anion gap. It's fine, okay. But you check the pH is 7.2. So there's acidosis, okay, with normal anion gap. So in this case, this is normal anion gap metabolic acidosis, like any smart doctor would do. What do? You order urine electrolytes, okay. So we know for the BMP, you just like subtract like the subtract chloride and bicarbonate from the sodium, and what left is the anion gap. For the urine, the chloride and potassium and sodium, what you would do, the potassium and sodium are positive, chloride is negative. All you care about the charge. So let's say potassium 20, sodium 20, that's 40, chloride is 80. So you see 40 minus 80, this is minus 40. So this is negative anion gap, Okay, so if you have normal anion gap in the blood, normal anion gap, negative anion gap in the urine, what does that mean? This means most likely. So why is this going on? Could be GI losses, gastrointestinal losses, what causes this acidosis. Okay, so this patient's having, so this is like a metabolic acidosis case. Okay, so whenever you have metabolic acidosis, you assess the anion gap immediately, okay, with reflex. If the anion gap is elevated, then you check the ketones, okay, in the blood or in the urine. If there is ketone, this is diabetic or alcoholic ketoacidosis or starvation ketoacidosis, okay? This is one of the three. If there's ketone in the blood. But what if there's no ketone in the blood? You check serum osmolality. If it's high, then it's methanol or ethylene glycol. If it's normal, this is paraaldehyde or salicylate, okay? These are don't increase the osmolality of the blood. This is the metabolic acidosis, normal elevated anion gap. What if the anion gap is normal? If it's normal, you want to check the urinary anion gap. If it is negative, then this could be diarrhea, laxative abuse, or enteric fistula. If it's positive, then it's renal bicarbonate wasting. Could be either renal tubular acidosis, carbonic anhydrase inhibitor, or low aldosterone states can cause that as well. Okay. All right. Now there is this interesting case. It's very high yield. A lot of them very common high yield. So 47-year-old man came in with fever, cellulitis. Okay, he was given clindamycin, failed clindamycin, so admitted, given cefazoline. Okay, so cefazoline after that creatinine increased, of course, to 1.9 from 1.2 increased to 1.9. So, and they're asking why is that? So like any smart doctor, you do urinalysis. Urinalysis shows to 15 to 25 white blood cells. So what is the diagnosis in this case? This is acute interstitial nephritis. Okay, this is acute interstitial nephritis, and as we said, happen with PPI, NSAIDs, antibiotics, Legionella, causes arthralgia, kidney injury. And you will see white BC cast, and urine eosinophil could be negative. This is how they trick you here. They tell you urine eosinophil negative. So it's not necessarily, you may or may not see it. It's not cut off. So it could be negative and still interstitial nephritis. Treatment, either you discontinue drug or change it, and then you do steroid. Okay. Okay, now this patient, you see 77-year-old male, came in with lethargy, poor oral intake, constipation. Okay, and then you check the labs. Calcium is 16. This is very high calcium. So what would you do? How do you manage it? Creatine is like 1.4. What's best next step? This one you need zoldronic acid. Okay. Zoldronic acid would be very helpful in this patient. Okay. So how do you manage hypercalcemia? There are different stages. If it's severe, moderate, or asymptomatic. If it is severe, there is short-term immediate treatment, like you do normal saline plus calcitonin, and you avoid loop diuretics unless this volume overload, like heart failure, exists. This is the short-term treatment. Long-term treatment, you give bisphosphonate and zoldronic acid. If it is moderate, like 12 to 14 milligram per deciliter, there is no immediate treatment required unless symptomatic, and treatment is similar to severe hypercalcemia, which is like fluid, just give them hydration, zoldronic acid basically. If asymptomatic or below 12, there's no treatment, you just avoid thiazide, avoid lithium, and volume depletion, and prolonged bed rest. You just give them fluid as well. Okay, so in a summary, hypercalcemia, just give them fluid and bisphosphonate. Okay. Now we have this patient, 33-year-old woman, came in with dyspepsia, and ultrasound shows 3 cortical cysts in the right kidney, 2 in the left, 2 in the liver. What is that? What's the diagnosis? This is autosomal dominant polycystic kidney disease, AD, PKD. This is autosomal dominant polycystic kidney disease. And usually it happens like there is known family history but unknown genotype. Usually you have more than 3 unilateral or bilateral kidney stone. Okay, if it's younger than 40, if it's above 40 years old, then 2 cysts in each kidney. That's classified as autosomal polycystic kidney disease. So if it's above 60, then you want a 4 cysts in each kidney. If you don't know family history, you need at least more than 10 cysts in each kidney, regardless of age. Okay, this is when you call it autosomal dominant polycystic kidney disease. Okay, now this case. So this case, the way you wanna, this case is interesting. So you see 44 came in unresponsive at home, slurred speech, you know. So you do regular labs like everybody. So you'd see there is normal anion gap. There's no anion gap, but the plasma osmolarity is a 350. It's high, you know. Usually it's around 300. This is high. This means there's extra substance in the blood that does not cause acidosis. And they give you all the options. Like they give you ethanol, methanol, isopropyl alcohol, diabetic ketoacidosis, alcoholic ketoacidosis, all kind of thing. And they ask you what is the diagnosis. This one, because there's normal anion gap. The only one that causes normal anion gap and elevated osmolarity. This is called isopropyl alcohol intoxication. Okay, so this is the only one that causes normal anion gap and elevated osmolarity. Everything else like ethanol, methanol, ethylene glycol, they have high anion gap, high osmolar gap. Okay, so this one just causes high osmolar gap, and coming from rubbing alcohol, hand sanitizers, and usually the acetone causes minor toxicity. Okay, this is isopropyl alcohol. Now this is another interesting case. So you see 71-year-old woman fractured her hip. Okay, so after fracturing the hip, normally you would do some tests, right? So you do test. What do you see in the test? You see normal anion gap. Okay, you see normal anion gap, but the pH is 7.3. So now they ask you, okay, what's the diagnosis? What are the things that causes normal anion gap, metabolic acidosis? What drugs? And they give you a list of drugs. In this case, is acetozolamide. This is just a memory question. You just gotta remember the drug that causes non-anion gap metabolic acidosis. Acetozolamide. Other drugs like topiramate can cause that. Cisplatin can cause that. Ifosfamide, aminoglycoside, Bactrim can cause that. Amphotericin B, lithium can cause that as well. They can add that. Pentamidine, rifampin, inhaled toluene. Okay, so these can cause normal anion gap, metabolic acidosis. Okay, now this case is interesting as well. You see 63-year-old man comes in with shortness of breath, cough, edema. Okay, on exam you see loud P2 and grade 2/6 systolic murmur on the left sternal border. Okay, so cough, edema, systolic murmur. Okay, you see creatinine is 1.5, pH is 7.48. Okay, so there is AKI, there is alkalosis. So now you ask, what is the PCO2? PCO2 is elevated. Okay, PCO2 65 and PaO2 is 84, which is okay. So now they tell you, okay, what could explain this patient's, okay, loud P2, there is wheezing as well on exam by basal crackles, what explain the alkalosis, and the patient has given Lasix as well, and the question is that what's your diagnosis, what cause explain that metabolic alkalosis, the respiratory alkalosis, metabolic alkalosis and respiratory acidosis, which one that causes metabolic alkalosis and respiratory acidosis. Okay, this is loop diuretics like Lasix and COPD. So Lasix and COPD can cause these issues, can cause metabolic acidosis and metabolic alkalosis and respiratory acidosis. Okay, so that brings us to the discussion. When you see how to evaluate pH, okay, it's pretty easy, straightforward. Okay, pH, either high alkalosis more than 7.45 or low, less than 7.35, this is acidosis. Okay, so if it is alkalosis, like in this case there's a pH alkalosis, you look at the PCO2, okay, and you look at the HCO3. If the PCO2 is low, this is a primary respiratory acidosis. Okay, if the HCO3 is high, this is primary metabolic alkalosis. Okay, if it's more than 24. Okay, simple as that. So in this case, the HCO3, what it was, the HCO3 bicarbonate 34. Okay, this is another thing, HCO3 is 34. This is primary metabolic alkalosis with respiratory acidosis. Okay. Now, so you can have secondary compensation, the opposite. If there's metabolic alkalosis, you have respiratory acidosis. If there is respiratory alkalosis, you have metabolic acidosis, because the opposite. Okay. Now, this is pH is high. If the pH is low, what would you do? This is acidemia, right? Then you look at the PCO2 and you look at the HCO3. If the PCO2 more than 40, this is primary respiratory acidosis. Simple, right? If the HCO3 below 24, this is primary metabolic acidosis. Simple as that. And the compensation is the opposite. If there's metabolic acidosis, you have respiratory alkalosis. The PCO2 will start dropping. If there's respiratory acidosis, you have metabolic alkalosis. The HCO3 is trying to increase. But always the metabolic compensation is lower than the respiratory compensation. Respiratory compensation is faster. Okay. Lung could help the kidney faster, but the kidney takes time to help the kidney to help the lung. Okay. Now this case is also a very nice case. So you see 61-year-old came in with confusion, right? So with confusion, nausea, vomiting, fatigue, excessive urination, you know. So you do labs, okay? Now the labs, that's what's going to tell you the magic, okay? You see calcium, 14. HCO3 bicarbonate is 34, okay? Then you check when there's calcium is elevated, as usual, you've got to check parathyroid hormone, you check vitamin D, PTHRP, all these things. All of them came normal. So what causes hypercalcemia with normal lab values? What's the diagnosis? That's what the normal PTH, vitamin D. This is milk alkali syndrome. This is the one that causes normal vitamin D, normal PTH. So this one causes milk alkali syndrome. Other causes for that: immobilization, vitamin A toxicity, acromegaly, adrenal tumor, multiple myeloma, and hyperthyroidism. Okay. So now that brings us for discussion of hypercalcemia. So if you have hypercalcemia, okay, confirmed on repeated testing, and ionized calcium, in some cases you can need that, then you measure parathyroid hormone. If it's elevated, then it could be one of two things: either primary or secondary hyperparathyroidism, or familial hypercalcemic hypocalciuria. Okay, hypocalciuria, urine calcium would be low, less than 100 in 24 hours. Okay, so check urine calcium. If it's less than 100, this is familial hypercalcemic hypocalciuria. If it's more than 250 milligram in 24 hours, this is primary or secondary hyperparathyroidism. But what if the parathyroid hormone is low? It's like below 20. Okay, this means it's parathyroid hormone independent hypercalcemia. independent, and it could be dependent on other things like vitamin D. 125 vitamin D could be PTHRB, or it could be 25 vitamin D. So if the PTHRB elevated, that's easy, this is malignancy. If it's 125 hydroxyvitamin D, this could be lymphoma or sarcoidosis that could convert 25 to 125 and act like a kidney. Or it could be just elevated 25 hydroxyvitamin D, this is vitamin D toxicity. If all of them are normal, then it's milk alkali syndrome, vitamin A toxicity, multiple myeloma, hyperthyroidism, the one that we talked about. And that summarizes this section. Okay, so we talked about milk alkali syndrome, Lasix and COPD. We talked about causes metabolic alkalosis. We talked about acetazolamide causes normal NGAP along with topiramate, you know. We talked about isopropyl, alcohol ingestion. We talked about Samandana and polycystic kidney disease, you need more than 10. Talked about zoledronic acid for hypercalcemia. Talked about acute interstitial nephritis. Talked about GI losses. And then we talked about how to maintain fluid in post-operative diuresis, post-obstructive diuresis. We talked about bicarb drop, how be very helpful for salicylic toxicity and how it's present. That concludes our discussion for this session. Thank you for listening.